Thank you, Mary. That was a great introduction. My name is Aimee Minton. I am from the Research Compliance Office, one of the most popular offices on campus. Maybe not the most well-liked, but we're definitely very popular on campus. I have been at Stony Brook University for 17 years. I started as a research coordinator in GYN oncology, then I went to radiology, and then I joined the dark side of campus. We're over in the Melville Library on the 5th floor. This is my colleague, Kozlowski. Luann is a nurse, and Luann has been in the same office, the Research Compliance Office, for 17 years. So I personally will tell investigators and coordinators all the time, I know how hard this is, I know how frustrating it is, I know it's a long process, but I've been there and I can help you. And so that's what we're here today to speak to you about. We're not going to talk about we're going to talk about data-driven studies, not so much about clinical trials and cancer studies and things like that. So let's get started. Yep. So what is the fundamental premise of the IRB? What is the function of the IRB? So there are federal regulations that mandate that research involving human participants must be reviewed by an IRB. The IRB is responsible for guidance and oversight of human protections and helps to ensure research is in compliance with applicable laws, regulations, and policies. We facilitate safe and ethical research. That's our job. And what is the foundation of these protections? Where do they come from? The Belmont Report. The document includes the 3 basic ethical principles for protection of human participants involved in research, directly or indirectly, such as respect for persons, beneficence, and justice. So anyone engaged in human subjects research is bound to comply with regulations and policies for protecting participants. I get this question all the time. Why do you guys come up with such crazy laws, regulations, policies? And I'll say to them all the time, it's the feds, it's OHRP, it's the Department of Health and Human Services. It's really not us sitting around trying to make things difficult on you. I promise it really isn't. So the first thing is, okay, I want to do this project, and we get these phone calls all the time, but is my study research? How do I know it's research? So what is the definition of research? And this is what we look at when you call us or we look at a study. This is my first knee-jerk response, is it a systematic investigation? Is it a methodical exploration of a question or theory? Typically includes data collection and analysis. It includes development, design, and testing phases. And the other key question I'll always ask somebody on the phone is, are you designing the study to contribute to generalizable knowledge? So is the activity designed to draw general conclusions, inform a policy, or generalize findings beyond a single individual or internal program? So not just our program here at Stony Brook in the peds, but in other hospitals at Mather or other institutions. Could it be generalizable? These studies they're typically designed to be generalizable if the research aims to draw conclusions about people or practices outside a specific individual or internal programs and could be applied beyond the population being studied. And I always say to investigators, what is your intent? If you start a QA/QI project, but at the end you realize it's generalizable, that's okay. It's a QA/QI project, and at the end you realize that it's something that could be generalizable. But what is your intent right now as your study design with your hypothesis? Is my intent to contribute to generalizable knowledge? So what about research activities that don't require review by our office? And we get these calls a lot as well. So things we don't need to review are quality improvement, QA/QI. They get uploaded on the IRB Net system, which we'll show you in a little bit. And Dr. Griffel reviews the hospital QA/QI projects. But quality improvement, quality assurance here in the hospital, or I get them a lot across campus, the psychology department with new classroom activities they're doing. QA/QI doesn't require IRB approval. Activities preparatory to research don't require IRB approval. Case studies, I treated a patient in the emergency room and had a really cool outcome and I want to report it. That is not IRB, that does not require IRB approval. Analysis of de-identified data sets Research with de-identified samples, deceased individuals, those do not require IRB approval. You may need other approvals with university hospital, like we were saying, like I said before, Dr. Griffel signs off for QA/QI projects. Some departments want to see your QA/QI project, but it does not require approval by the ORC office. So the application route you take depends on the level of risk, and that's federally determined. So there are two levels of risk. So if there's no foreseeable risk, you're doing a survey study. It falls into an exempt review category. If it's minimal risk, then it fits into the expedited review category, and the full application is completed. If you have an activity that doesn't meet any of the federal categories, then it comes to full. Some of the computer science, virtual reality studies, I'm not afraid you're going to kill somebody, but I can't make it fit into the federal regulations in certain categories. So therefore, I have to bring it to the full committee for review. You want to talk about exempt?
Yeah, I'm going to just talk about exempt research a little bit. That's one of the categories, and a lot of people hear that word exempt, and they think, oh, we don't have to go to the IRB, it's exempt. It just means that it's exempt from the federal regulations. There's still institutional review, internal review that needs to occur. You still submit to research compliance. And we're still looking at the ethical conduct of the research. You will need approval for protocol changes, and you will need to renew it every 3 years or so. So basically, there's several categories of exemption, but for data, the one that you really...
Okay, sorry.
Close enough, sorry. Sorry. But for data, it's exempt category 4, and that's going to be a retrospective chart review. A lot of people say, oh, it's just a chart review. It's not, I'm not even dealing with the humans. What risk could there possibly be? It's fine. But that data is attached to a human, and that's what we're looking at. We're looking at protecting their privacy of their data. They have the right to have that private and not just be used by anybody. So we want to make sure it's used properly, and that would be your exempt category 4 exemption. And that's going to be, to qualify for exempt, it's going to be existing data only. It can't be prospective. So it all has to, when you apply to the IRB, all that data has to be on the shelf somewhere. So you kind of want to equate it to a file box of records somewhere. And then you have to not collect any of the 18 HIPAA identifiers. It has to be completely de-identified. And that means no dates, no names, nothing that could link it back to the subject. And a lot of people get confused about what those identifiers are, which we'll get into. So we kind of talked about clarifying what existing data is, and it's, again, existing prior to the IRB submission. Nothing that's going to be collected in the future. Even though you as a researcher might not be getting it in real time, it doesn't exist when you apply, and that's the only way it's going to fit into that exempt category. And getting into the HIPAA regulations, this is where the 18 HIPAA identifiers come into play. You cannot have any master code that can't be coded. You can't have the dates. And I talked about that already, that you can't have any links. It truly has to be de-identified. You have to have that data on a case report form that you've submitted to us for review and approval. And you cannot know where any of those data points come from. If you were to pick it up, you should not be able to figure out where it came from. That's how you make sure it's de-identified. And I know there's some, you think that, oh, this random date, like say a surgical date, wouldn't count, but it does, because you could go into that day, maybe only 5 people had this particular surgery on that day with these symptoms, and you could slowly link it back. The way data works these days, it's amazing how you can find people and link people. So this just goes over the list of all the things that are de-identified. So it's names, address, telephone numbers, social security numbers, dates. The only thing you can collect is maybe years. They're 89 years old. You could collect something like that, but you can't collect their surgical date. You can't collect the surgeon that did the surgery. You can't collect those things. And pretty much this will give you the whole list, and we have that up on our website. When you submit these applications, that's something that you would need, and we have that form available on the website for you. So again, what does this really mean? It means the only thing that's going to qualify under an exempt review, where it's an internal review by our office, not going to the committee, is something that's going to be a retrospective chart review that's de-identified. That's something that you can go in, collect all the data in one fell swoop, and be done. So you can't have a temporary code, say I want to go to radiology and collect some data, I'm going to code it number 123. I'm going to go to the EMR and collect something else. That's a temporary code. You can't do that either. It has to be one thing. So the only way to do it is to maybe have some diagnosis codes. You go to IT, say I need these patients with these diagnosis codes. They will give you the MRN on a list separately with no other identifiers. And then you can go into the record and you can pull in one time frame the data that you need onto the data collection sheet that our office has approved. And then that MRN list is destroyed. So then you're done with it at that point. This is great if you just know you have a basic study that you want to do. There's no reason it has to be exempt. It can go expedited. You can keep a code, because you might find in those data points you collected, wow, I found this interesting trend, but I didn't code it. So now I can't go back and pull more things. So maybe you do want to code it, but you're just going to have to go the expedited process to do that. And that's not that hard either. It's just maybe another extra little step in the process of your application to us. And then I think that's Aimee.
Okay, so the expedited review process. I have a prospective data collection. I have a code. I need the MRN. I'm going to look at pathology samples and then go to radiology and look at the CAT scan results. So that's the expedited review category 5. That federal category states it's research involving materials, data, document, records, or specimens that have been or will be. So anything that you're going to be looking at that would be collected the day after you submit the application to us is prospective. So that is a lot of the studies that you're usually involved in. So then we have this expedited review category. You have the application. We always get this question. You're either going to get consent from the subject, or you're going to apply for the waiver of consent, which is most of the chart review studies are and data collection studies are. And then we have these 3 HIPAA forms in our library. And people call all the time and say, well, which one do I need? So if you have a code like an MRN, and you're going to keep that separate, but it's coded, and you can go back and fully identifiable to your subject, then that's the HIPAA waiver of authorization form. If you're collecting a limited data set, which is like a registry or a number that's going to link things together, but it's not the encounter number, it's not the MRN, that would be the limited data set HIPAA form. And those are in our IRB net forms and template library that we'll show you in a little bit coming forward. So again, when you're getting when you're putting in your study, you're either getting consent from the subject via the consent form, or you're uploading one of those HIPAA forms and getting a waiver of authorization from the subject. If it's the de-identification, you don't need any of the 18 HIPAA identifiers. It's the HIPAA de-identification form. And then if you're going to have the registry or a unique code, that would be the HIPAA LDS. If it's an MRN, or sometimes studies are fully identifiable, it's the HIPAA waiver of authorization form. Okay, so what do you need to submit to us? What do we want to see? We want to see your application, your protocol, your data collection form with who's collecting the data on the form, your HIPAA form or a consent form, the registration form, and if it's dealing with sending the privacy officer, Stephanie Musso, needs to be involved in if you're sending data outside of Stony Brook. So then we also need the UH form as well. You want to talk about IRB now? Okay, so what is the electronic system? The electronic system that we're using right now, well, till the end of the summer, is IRB-Net. So on this slide, we just gave you a screenshot of IRB-Net itself. And so when you log on, you put your study on the left-hand side are all these radial tabs. And one of the tabs is the form and template library. And if you click on that, We have all the forms, and there's instructions too. There's a submission requirement, nice little spreadsheet that comes up and tells you, okay, for exempt studies we need this, for expedited studies we need this, and for full review studies we need this. So that can all be located in IRBnet Forms and Template Library. And also one of the requirements is that you have human subjects training. Even if you're just doing data, tissue, that type of training, you know, well, I'm not interacting with subjects, I'm not consenting them, why do I need human subjects training? It's a requirement, it's a federal requirement. The NIH doesn't hand out the money for award until we supply them with the investigator city certificate. So you have to do the training first. We do not approve your study till you and everyone listed on the registration form have city training on completed, and so you definitely need to get that done. And this is a screenshot from the website. It didn't come out that great, but our website is the, you know, if you go onto the research, Stony Brook Research, and if you look up Office of Research Compliance, and we have like the overview of human subjects, the IRB information, when the meetings are, the deadlines for the meetings, and our SOPs, which is our standard operating procedures that we follow. All right, so we'll take a minute. So coming soon, what's going on in ORC? So right before President Obama left, 2 days before, he changed the federal regulations, the common rule change, and he issued a new change into the federal research regulations that we all follow. They were supposed to be effective January. The Trump administration put a hold on it and said, let's put a hold on it till July and we're going to review it. So the proposed common rule changes affect all of us. And it's going to affect our policies and our procedures. And the word on the street is the Trump administration is going to change them a little bit. So I was going to give you a little bit of insight on how they look now, but you know, I didn't want to give a lot because we don't know how they're going to be changing as well. So the major regulation change, our consent form is going to look very different. One of the big public comment is these research consent forms, especially oncology and cancer studies, are 38 pages. We have some of the children's pediatric oncology studies that are 38, 28 pages. So the new federal regulations, there's a big push to put the valuable information up front in the beginning of the consent. Don't put the risk on page 30, the risks and what's going on, you know, the most upfront things they want on the front of the consent in the very beginning. So we're going to have to be fixing our template to comply with that. The one thing that I'm very excited about, if this happens, is continuing review. So your retrospective chart review studies that we make you renew every year in our office, because you say, you know what, I'm still collecting data. I'm still analyzing coded data. I'm still collecting data. Those do not have to be submitted for continuing review anymore under the new regulations. When it goes into effect. If you're only doing data analysis or you're only following up people for clinical care. So we have some of these pediatric oncology groups where the study ended 15 years ago, but they follow these kids for life. And every year we review them. So this would be really awesome if this actually goes through. And I think this will help a lot of investigators too. All these chart reviews that are open for data analysis for years and years and years. Hopefully, with the new federal regulations, we won't have to review them yearly. That would be really great. That would be great for you guys and great for the IRB as well. There's some new exempt categories. There's a couple of new, I don't think it's really for this crowd, but benign behavioral interventions. Because the regulations are so old, you know, they were the last time they were revised were in the 60s. There's no regulation categories for online activity, for computer games. And so they're looking at some new benign behavioral intervention where you can interact with people online and they would make that an exempt category. So that would be good. And then another hot button topic is something called broad consent for data and tissue. And this is something a lot of institutions are struggling with because we're not sure how we would implement this. But the federal regulations are saying instead of getting IRB approval and consent for each individual research study with tissues and data, you could have a broad consent. So I could come in as Stony Brook as a patient and be handed a broad consent and says, do I allow my data and tissue from my surgery to be used for future research at Stony Brook? And then you as the researcher would just say on your application, I'm going to get my specimens from the broad consent population, from that population that said they're okay with being in research. So it's really new. The feds haven't given us much guidance on it. I think it's great if people say yes, but if they say no, how are we going to track all that? I mean, that's the big issue that comes with this, is if somebody says no, we have to make sure Mary Smith, her tissue, her data never gets sent out. So, gets used for anybody here. Or what if I say it's okay for radiology, but I don't want pathology taking any of my data? So, it has a lot of issues. So I'm not sure what's going to happen with the final rule, if they're going to give us some more guidance on that. And then we'll have to see at Stony Brook here, like with a lot of institutions, how we would handle that and how we would implement that. Another good thing too is they actually have a proposal for that exempt category number 4 to include research using identifiable data. Luann just gave you all the speeches that to be exempt, it can't be identifiable and it has to be existing. There's a big push to change that, that there can be identifiable information and it can be prospective data review. So we'll have to see what those guidelines come out to be as well. But that would be something that could possibly affect you as well, that where before you had to have the expedited review, you had to renew it every year. With the new regulations, you may be qualified for exemption. So you may have approval for 3 years on that. So again, we have to see how that comes about. The government also has something called a limited IRB review on certain exempt studies. It's more on the social behavioral type studies, but they don't define what limited IRB review is, so we have to figure out what that is. And that they also just suggest for some of the exempt determinations, there could be like a self-determination checklist by the PI. And that is also in regards to like the social behavioral studies. So that's something we'll have to see what the guidance comes in the future. The common rule is also stating that as of January of 2020, for federally funded studies, there'll be a single IRB of record. And the NIH has already started this single IRB of record as of January 25th. We get a lot of phone calls about single IRB. And actually, Luann is the Reliance administrator, and she's been doing a lot on single IRBs. So I just want to take a minute and let her discuss that. I'll leave it on my phone. Thanks.
Yeah, the single IRB is actually great. So just in January, it became effective that for NIH single IRB studies, meaning same study, multiple sites, you have to use a single IRB. So it avoids having multiple IRBs reviewing the same study, coming up with different outcomes, which is never a good thing. So the single IRB is great. What I'm finding is that everybody is starting to use them. The trend is going to single IRB for multi-site studies. So I am inundated with calls and requests about relying, and there's some great tools out there for those. If you are involved, even data studies, there's a lot of data studies that you want to use multiple sites, and how much easier would it be to go through one IRB instead of multiple? So that is something we have. We're on the Smart IRB system, meaning there's several institutions on the Smart IRB system, and it's a common reciprocal agreement that we all agree to rely. And then per each study, we then make a determination to definitely rely on that. Each institution has to provide some local context information. And then that kind of takes a little bit of a process in the beginning. But then once that's hashed out, you just have one IRB that you are responsible to, other than our local review, which we have to make sure you have training, and we have to make sure you have data use agreements, those types of things that will occur no matter what. But as far as the main review, it will happen in one place. So that's something that we do have available, and if you ever have any questions about that, please feel free to call our office. I guess we're
running out of time.
Running out of time,
Do you have
so
any questions?